Okay, episode 14. Young, fit, and hypertensive. 17-year-old woman was referred to a specialty clinic secondary to severe hypertension at a young age. Her hypertension was diagnosed incidentally 1 year earlier at the age of 16 years old during a routine follow-up after she was prescribed a combined oral contraceptive pill. She had no significant medical history and her family history was negative for hypertension. The patient was a high-level athlete and complained of frequent headaches. She denied recreational drug use, no doping agent, no licorice consumption. Her blood pressure in the office was 166 over 92 millimeters of mercury. The physical exam was otherwise unremarkable. Her body mass index was 22. Given her age and athletic status, potential underlying causes of hypertension were explored by the authors, including what was thought to be initially drug-induced hypertension. I'm going to talk a little bit about drug-induced hypertension because it is a very common cause of secondary hypertension in young patients. The oral contraceptive pill was the prime suspect in this particular case, and estrogens can elevate blood pressure through several mechanisms, including increasing hepatic production of angiotensinogen, activating the renin-angiotensin-aldosterone system, stimulating the sympathetic nervous system, and influencing antidiuretic hormone release. In normotensive women, low-dose estrogen progesterone combinations can cause about a 5 millimeter per mercury increase in systolic or diastolic blood pressure, and the incidence of developing hypertension is approximately 2% over 4 years. There are even case reports of malignant hypertension induced by oral contraceptives. However, in this case, when the athlete discontinued the oral contraceptive, her blood pressure remained elevated. 3 months later, hypertension was confirmed by 24-hour ambulatory monitoring showing both systolic and diastolic hypertension throughout the entire 24-hour period. Her daytime average blood pressure was 182 over 121, and nighttime her average was 172 over 107. Initial laboratory workup revealed hypokalemia, a potassium of 3.3 with inadequate urinary potassium excretion, which the authors measured at 43 millimoles per 24 hours. The combination of hypertension and hypokalemia expanded the differential. The authors listed the following: primary aldosteronism, renal vascular disease, Cushing syndrome, congenital adrenal hyperplasia, apparent mineralocorticoid excess syndromes, and rare genetic causes. Her EKG revealed left ventricular hypertrophy. In athletes, left ventricular hypertrophy is a physiologic response to increased hemodynamic demands. Athletes typically exhibit increased left ventricular diastolic dimensions, enhanced cardiac filling and compliance, and often bradycardia from increased vagal tone. In contrast, hypertensive heart disease often shows diastolic dysfunction due to increased stiffness and impaired relaxation. Key differentiating features favoring physiologic hypertrophy include large left ventricular cavity size, uniform pattern of thickening, normal diastolic function, and absence of T-wave inversion on EKG. In this particular patient, echocardiography showed concentric left ventricular hypertrophy, and the left ventricular mass index was 111, above the normal limit of 95 for women. However, given her high-level athletic training, the authors attributed increased left ventricular mass to physiologic adaptation rather than underlying cardiac disease. Her kidney function was normal, with a glomerular filtration rate of 100 and normal urine albumin to creatinine ratio. Imaging studies were pursued, including renal artery ultrasound and CT scan, and they showed no abnormalities. Additional differential diagnoses for secondary hypertension could include aortic coarctation, obstructive sleep apnea, use of nonsteroidal anti-inflammatory medications, stimulants, certain supplements, anabolic steroid use, alcohol use, and, as mentioned before, oral contraceptives. I want to take a minute to recognize the authors, Drs. Lopez and Guerrot. They published this in the journal Hypertension in 2024, and They are both practicing in France, but it's a really nice case study. I'm Scott Hull, a primary care sports medicine physician, and I'm studying for my sports medicine recertification in 2026 by reviewing relevant case studies. You're welcome to join me on the journey and hopefully learn something along the way. This podcast is for educational purposes only. Okay, so when the authors pursued further evaluation, hormonal assessments told a fascinating story. Plasma aldosterone was 36, which is low, with a normal range of 55 to 422. Plasma renin was less than 2, which was also suppressed, with a normal range of 5 to 45. In 24-hour urine, aldosterone was just 3.4, again low. A dexamethasone suppression test was normal, ruling out Cushing syndrome. Urine cortisol, metanephrines, and norepinephrines were all normal, ruling out pheochromocytoma. In summary, the athlete had hypertension, hypokalemia, low renin, and low aldosterone. This pattern is called pseudoaldosteronism, where clinical and biochemical features mimic aldosteronism, but renin and aldosterone levels are both suppressed. The differential now narrowed to exogenous or iatrogenic Cushing syndrome from corticosteroid use, licorice ingestion, congenital adrenal hyperplasia, and genetic mutations. In this case, the toxic causes were excluded and the biochemical picture pointed to pseudoaldosteronism. Genetic testing was performed and it confirmed a diagnosis of Liddle syndrome. I want to spell that Liddle, Liddle syndrome. It is a rare autosomal dominant condition that mimics mineralocorticoid excess due to mutations in a gene encoding a subunit of the sodium channels of the kidney, which results in enhanced sodium reabsorption and potassium excretion. Now, the standard treatment for Liddle syndrome is epithelial sodium channel blockers, specifically amiloride or triamterene. These drugs directly block the overactive sodium channels, addressing the root cause of the problem. This patient is a high-level competitive athlete, and amiloride and triamterene are classified as banned substances by the World Anti-Doping Agency. Because diuretics can be used as masking agents to hide the use of other prohibited substances. They are both on the WADA prohibited list regardless of therapeutic indication. So, the team elected to manage her with a high potassium diet and amlodipine. Athletes with legitimate medical conditions could also apply for a therapeutic use exemption, which allows them to use otherwise prohibited substances. But this case highlights the regulatory complexity and the need for careful documentation and even advocacy. This is an important consideration for any sports medicine physician managing athletes with conditions requiring medications on the prohibited list. A couple of key takeaways. Number one, hypertension in athletes represents the most common cardiovascular risk factor in an athletic population. Despite regular physical activity, hypertension remains prevalent, particularly in certain sports and populations. Number two, athletes with confirmed hypertension should undergo evaluation for secondary causes, including assessment for aortic coarctation. This could be assessed using a blood pressure measurement in both the arms and the legs. Other considerations would include obstructive sleep apnea, use of anti-inflammatory stimulants, supplements, alcohol use, oral contraceptives, and performance-enhancing drugs. Hypokalemia was a key factor in our case, and it is also one of the key factors associated with higher prevalence of secondary hypertension. Third, differentiating physiological left ventricular hypertrophy in athletes from pathological hypertrophy requires integration of echocardiographic findings, EKG findings, and clinical context. Fourth, most athletes with stage 1 hypertension without target organ damage can participate in all competitive sports. However, with those with stage 2 hypertension, which is defined as greater than 160/100, should be restricted from high static sports, with examples being weightlifting, boxing, wrestling. So athletes should be restricted until the blood pressure is controlled. Okay, practice questions. Number one, a 22-year-old college football lineman has a blood pressure that was measured as elevated. Two readings were obtained, with the first 148/92 and the second 152/94. Both were obtained at a preseason physical exam. What is the most appropriate next step in confirming a diagnosis of hypertension? Answer: serial ambulatory blood pressure monitoring or repeated measurements in the training room using an appropriately sized cuff. Common thing that I see is measuring a blood pressure cuff on a husky athlete, which is undersized, therefore the readings tend to be elevated. Athletes require special consideration for blood pressure assessment. The American Heart Association recommends averaging 3 measurements in each arm separated by at least 1 minute. Appropriately sized cuffs are, of course, crucial, and the cuff bladder should encircle at least 80% of the arm. Athletes, particularly those with large arm circumference like football linemen, may have falsely elevated measurements with undersized cuffs. Additionally, preseason physicals occur during periods of high psychological stress, which can lead to falsely elevated readings. Ambulatory blood pressure monitoring provides the most precise means of confirming hypertension in athletes. Okay, question 2. 19-year-old competitive wrestler is diagnosed with stage 2 hypertension. His blood pressure was 165/105. He has no symptoms and a normal physical examination. What sports participation restriction should be recommended? According to the American Heart Association and the American College of Cardiology, would be restriction from high static sports, including weight lifting, wrestling, and boxing, until the blood pressure is controlled. Question 3. A 25-year-old marathon runner with newly diagnosed stage 1 hypertension requires pharmacotherapy after lifestyle modifications. Which class of antihypertensive medication is most appropriate as first-line therapy? Answer: pharmacotherapy should prioritize vasodilators with minimal effect on exercise physiology. ACE inhibitors, angiotensin receptor blockers, or dihydropyridine calcium channel blockers are considered first-line therapy for our athletes. These agents are preferred over drugs with negative chronotropic effects like beta blockers and diuretic agents, which may affect both chronotropic function and predispose to dehydration during vigorous training. Competitive athletes may require therapeutic exemptions from many guideline-based therapies when prescribed diuretic agents. Something to keep in mind. Okay, question 4. A 20-year-old basketball player with confirmed stage 1 hypertension with a blood pressure of 142/88 has no target organ damage on echocardiography. What sports participation recommendation is appropriate? Answer: full participation in all competitive sports is permissible with blood pressure monitoring every 2 to 4 months. So stage 1 hypertension without target organ damage should not limit eligibility for athletes. Once training begins, the hypertensive athlete should have blood pressure measured every 2 to 4 months or more frequently if indicated to monitor the impact of exercise. Screening echocardiography is recommended for athletes with sustained hypertension to distinguish physiologic hypertrophy versus pathologic left ventricular hypertrophy from hypertension. Thank you very much.